Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent education grant from Insulet.
Hello, everyone. My name is Dr. Grazia Aleppo, and I am delighted to invite you to join me today for this Ask the Expert, Best Practices in Using Automated Insulin Delivery to Achieve Outcomes Faster and Safely in People Living with Type 2 Diabetes. I am a professor of medicine in the Division of Endocrinology at Northwestern University in Chicago. And today I'm delighted to be joined by my dear colleague, Dr. Seth Kramer, who is an assistant professor of medicine in the Department of Family Medicine, University of Colorado in Aurora. So today is the first in a three-part series on the use of AID systems in people with type 2 diabetes. In this program, we will discuss the latest evidence in the clinical trial for and the best practice related to the use of AID systems in people with type 2 diabetes to optimize glucose control and improve patients' outcomes. With this, I'll give the microphone to Seth. Seth, take it away.
Great. I want to take a moment right now just to pause, reflect on our current practice that many of us have, whether it's in primary care or another specialty. Consider whether you're actively titrating insulin doses for your patients with type 2 diabetes. Ask yourself, are my patients really reaching their glucose targets? And if they're not, is an insulin adjustment needed to reach better outcomes? Clinical inertia is one of the most significant barriers to achieving glycemic control in our patients with type 2 diabetes. It's defined simply as the lack of treatment initiation or intensification, despite there being clear evidence that a patient hasn't reached their glycemic goals. This is a critical issue. I see it often in my own practice, and we need to address it to attend to what we see often occur. There are several factors to why inertia happens. There are provider-related factors, so concerns about hypoglycemia, medication side effects, or uncertainty about when to intensify dosing. There are patient-related factors, so adherence to challenges, cost concerns, or reluctance to add medications. And then there's system-based factors where there's a lack of structured follow-up, inadequate monitoring, or there's time constraints in clinical practice, which we often see, and that's hard to incorporate other things into our care. Patients on multiple daily injections face a lot of barriers. There's complexity sometimes to the regimens, injection burden, quality of life impacts, which can contribute to both patient and provider hesitation about intensifying. So this is where AID systems become particularly relevant. By automating insulin delivery and reducing the burden on patients, AID can help overcome some of these barriers to treatment intensification that we see. Rather than adding more injections or complex regimens, AID offers a more manageable pathway to achieving glycemic targets, which is why it's now, the preferred insulin delivery method according to 2026 ADA standards of care. How common is clinical inertia in those with type 2 diabetes? Fewer than 50% of patients with type 2 diabetes who had elevated hemoglobin A1C levels received appropriate treatment intensification. That means that more than half of our patients with above target glucose levels weren't getting the care adjustments that they needed. And even more concerning is that we see clinical inertia present in more than 26% of our patients who have a greater or equal than 7% A1C, and 18% of those with an A1C of greater or equal to 8%. So these patients continue to fail to receive medication intensification even after a follow-up of more than 4 years. So we're talking about years of suboptimal control. So, AID works, but to see that success in real world, we have to understand, there are 4 interconnected barriers to incorporating. There's, take behavioral limitations. Patient fears going low. They might override the bolus amount. They get burned out by the alarms, and their time in range plummets. Consider physiological limitations. An older patient with high insulin resistance may still see severe post-meal elevations of their glucose, because their delayed absorption simply kind of outpaces the system. And then add technological hurdles. So like a lost sensor signal on vacation, or a patient with high daily insulin needs who has to frustratingly, refill their pump, every 1 or 2 days. And then finally, systemic challenges often mean that these devices are never even initiated. So if clinics are bogged down by, insurance delays or lack of workflow to manage, this technology remains out of the reach for patients who might need it and utilize it best. So these challenges aren't reasons to avoid AID. They are simply reasons to, plan ahead. So when we acknowledge these barriers up front, I think we can, strategically kind of have a path to successfully integrating it into our practice. The clinical evidence for AID in people is compelling. So Dr. Aleppo is going to walk us through the data here in supporting this.
Thank you, Seth. So the question that I want to pose to you is, are you thinking about AID as a safe and effective method for therapy for your patients with type 2 diabetes? And why do I ask this question? Because the ADA thought about it. And in fact, this year, as Dr. Kramer was already alluding to, and in the standards of care that are published every year, this year it says AID system are the preferred insulin delivery method over multiple daily injections, standard pump, sensor augmented pump for people with type 1 diabetes, and look in red, adults with type 2 diabetes. And this is A-level evidence. I'll show the evidence in a minute, but that's a very important, it's the highest level of clinical evidence. And you see down here in 725B in the recommendation, consider AID system for select people with type 2 diabetes that are treated with basal insulin who are not achieving individualized glycemic goals. So if we think about patients who struggle with their glucose and they are on massive doses of basal insulin, why not instead consider an AID system? And let's see what the data will show us. Today we have 3, to this day, approved systems for AID in type 2 use. Omnipod 5, to sleep with X2, Control-IQ Plus, the Mobi also, and the MiniMed 780G pump. So we'll start with the Secure T2D study. So this was done to verify the efficacy and safety of the Omnipod 5 use in people with type 2 diabetes. This was a single-arm prospective study that really showed the effect of Omnipod 5. It was about 300 people with type 2 diabetes The mean age was 57. The 50% or more were female. The BMI was pretty high, 35. The duration of diabetes was 17 years, and the baseline A1C was 8.2%. You want to see how this group was very heterogeneous, with 50% Caucasian and almost 50% between Black and Hispanics. You also see how a good percentage of participants were using already CGM, 62% of them. So what happened after 13 weeks of the use? Overall, there was a 0.8% decrease in hemoglobin A1C from 8.2 at baseline to 7.4 at the end of the study. But then you wonder, does it make a difference if a patient is coming from multiple daily injections versus basal? Well, the second portion of the slide on the right side shows that not only the people with multiple daily injections did well, but look at those from basal. They had a 1.2% decrease in hemoglobin A1C, showing how effective this method of therapy really is for these patients who don't achieve glycemic targets. I also want to show the effect on time and range. The patients who were using the Omnipod 5 saw at the end of the study an increase of 20%. It's almost 5 hours per day in range, from 45% to 66% at the end of the study period, and a concomitant, by the way, identical decrease in time above range of 20%. So again, you see how the glucose become flatter with less fluctuation, while at the same time having very minimal and non-different amount spent in hypoglycemia less than 70, very low at 0.2%. What I want to show here also is the effect of baseline A1C on these participants. You can see how if you had a time A1C that was a target already before starting, you might have seen maintenance, which is great, of the A1C. But look what happened to those participants who started at very high A1C, up to 10%. Those individuals saw a 2% reduction of A1C, the no increase in insulin dose will ever be able to achieve. And this was able to achieve, and I'll show you in a moment what the insulin dose were, by the way. And you can see how, whether you're Black or Hispanic, you had even better results than the Caucasian ones. But people keep asking me, yes, but we are in the age and the era of GLP-1s. So do our patients need to be on AID systems? And the answer is absolutely. Look what happened to the participants who were using AID and GLP. Whether you were a GLP user or not, once you went on the Omnipod 5, your A1C went down by 0.8% or 0.9%. And you can see also how, whether you count carbs or you don't, you had the same result in the participants after the end of the study who were trying to use the Omnipod 5. And so you can see you don't need to be a carb counter. You can use small, medium, and large. You can use fixed doses of insulin, or you can count carbs. It's up to you. And then we can see how an important thing we forget sometimes about a patient to use insulin, how the diabetes distress was reduced with the use of AID system. So when you think about diabetes distress, a higher than 2, it's a very high level of distress. So can we actually improve the level of distress by giving our patients an AID system? And in the study, the participants that did the SECURE-T2D study, you can see how their stress went down all the way down to 53% compared to 66% baseline. This shows that even though people might think that it might be a more complex system to use, in fact, their distress about having diabetes and feeling a failure went down substantially. We now move to the real world outcome. These are 400 adults with type 2 diabetes, and you want to see in the 3 slides I'm showing you how that if you look from young people to middle age to over 65, look how very low the time below range was across. So if you think about people at high risk for hypoglycemia, the older people are doing phenomenally. But keep looking. Look at this time and range. If you look at the 70 to 180, the younger people were at 68%. Look at the over 65. They went all the way up to almost 75% in range, while at the same time using a very small amount of insulin per day. The same for all the 3 groups, showing how the modulation of insulin delivery with AID system really optimized the distribution of the insulin delivery. And now I'm going to show you to IQP study, which was a randomized controlled trial, which was studying the efficacy and safety of the T-slip with control IQ plus between CGM and group like MDI group versus AID. This was a randomization 2-to-1 of 13 weeks trial. So the baseline showed that the age was similar, 59 to 57, 50% female, BMI again 33 to 35, so elevated, similar duration of diabetes, about 18 years, similar A1C in the 8%, and you can see there was a little bit more Caucasian, but still a by distribution of participants were also using CGM prior to starting the initiation of this study. So what happened? Well, look at this. So between the two groups, there was a substantial decrease in hemoglobin A1C of 0.9 in the AID group compared to 0.3 in the control, with the mean difference between groups of 0.6% hemoglobin A1C. But on the right side of the screen, what you want to see is how the time in range separates at day 1 and continues to stay very separated with increasing time in range of at least 10 to 16% in the group using the AID system. Not only that, the hypoglycemia was basically not remarkable, less than 0.9, which is according to the guidelines, for less than 54 milligrams per deciliter. And then again, as I showed you before, we had groups of patients in the study where I actually was part of the site. But you can see how you could be on GLP, no GLP, SGLT2, no SGLT2, or a combination of the two. In both situations, all of them, you saw that the group on AID had a much better improvement in hemoglobin A1C compared to the control group CGM and the usual care. Furthermore, we always have this concern about C-peptide. So patients who are on Medicare, they have to show that they're insulin deficient in order to be able to get an insulin pump covered through DME from Medicare. Well, the study showed that there was no difference whatsoever between the participants, whether you have a measurable or high C-peptide versus a low C-peptide. They did exactly the same, and the AID did much better than the group in control. Then we go to the IMPACT-2D, which used the MiniMed 780G system. This was a group of 95 adults with 13 sites, was open label, a single arm with 2 weeks, up to 3 weeks in run-in, plus 90 days in hybrid closed loop. So the age was similar, again, 50% female, same BMI, 35 to 36, duration almost 20 years. The A1C was a bit lower in this group, and there was a greater amount of Caucasian participants compared to the other groups like Black or Hispanics. Some of them were already on insulin pump. If you see what happened at the end of the study, you can see that compared to baseline, at the end of the study, there was a decrease in A1C from 7.9 to 7.2%. And you can see how between the white and the blue bars, so baseline to AID time, there was much better group of A1C less than 7%, time in range over 70%, or time in entire range over 50%, hypoglycemia, and combined outcomes, they were really so much higher at the end of the study using the AID system. In addition, you can see from this very large group of real-world participants how whether you use less than 100 units per day, more than 100 units per day, you always do better when you're on AID. And look also the time it ranges, 75, 76%, and the GMI, the glucose management indicator, is actually low to 7 or 6.9%. So if you think about this thought that I just showed you, we should think a couple of things. Number one, age should not be a barrier to using AID to our patients with type 2 diabetes. I showed you, you might need to do a bit longer education, but once they start and they understand the system, they actually are very excited and they engage in using the system. Then you can also, remember, reduce substantially the total amount of insulin dose per day. We saw, and actually every study saw, about a 30% decrease. So when we think, oh, this patient needs a lot of insulin, very often we are over-insulinizing these patients, over-basalizing them, and not really do the right distribution of the modulation that the AID can do. But also I showed you 3 very different clinical trials. They showed the same results. Time in range improves, There is no increase in hypoglycemia in any of the study, in any age, and the benefits are independent of C-peptide levels. And with this, I want to give back the microphone to Seth to implement the use of AID in type 2.
Take a moment to think about now a specific patient in your practice with type 2 diabetes who might benefit from AID, someone with suboptimal glycemic control, despite current therapy, or someone who's just struggling with burden of the multiple daily injections, and consider what barriers they might need or face and what support would they need to continue. So let me walk through a real patient scenario of mine. This is a 62-year-old man with type 2 diabetes, 12 years. He's on glargine, 68 units, long-acting, daily, plus semaglutide, 2 milligrams weekly. His A1C just ticked up to 8.4% from 7.8%. He's gained a little bit of increased weight. And he's tech savvy, he's motivated, but he absolutely refuses to do multiple daily injections. I see it often, and this was of no surprise. He's frustrated because despite the GLP-1 agonist or semaglutide, his glycemic control's slipping. Look at the CGM metrics just below there. Time in range is only 52%. He's spending about 45% above time of range or above 180. He's seeing post-meal hyperglycemia hitting up near 250 to 300, and his glycemic variability is 24%. He's not seeing any hypoglycemia, only about 1% time below range. So safety is not the barrier here. Really, basal insulin alone can't handle his postprandial glucose excursions, and thus we need to look at some additional options. This is the perfect AID candidate. He needs prandial insulin coverage, but he doesn't want to involve himself in multiple injections. AID may help solve this. No manual injections. We're not required to need carb counting. Often that's not something that comes with those with type 2 and on insulin, and that's especially the case with a fully, closed loop system where we don't need to involve that part. To reiterate, 2026 guidelines, state that the AID's preferred insulin method for adults with type 2. It's not just an option, it's preferred. So look at the outcomes. A1C reductions up to 2.1%, time in range improvements of 21% points. And looking at that, that's about almost 4 hours per day in target range with no increase in hypoglycemia. So for this patient here, this means that his A1C could potentially come down from that 8.4% down towards 6.3%, and his time in range could jump up from 52% to 73%, or up where we would like to at least see him. So, this really illustrates the elegant kind of simplicity of how AID actually works and why it's so effective for people with type 2 diabetes. There are 3 integrated components working together in real time. So first, sensing. The continuous glucose monitor constantly measures glucose levels throughout the day. Second, modulation. The control algorithm, the brain of the system, analyzes that glucose data and makes automated decisions about the insulin dosing. And third, insulin delivery. The pump delivers the precise amount of insulin. The algorithm calculates, adjusts, over its total daily dose and how much we know they've had, and based on the current glucose trends. So, this is a timeline that's standardized, really, the transition to AID to the patient, the device, the care team that we have, and that they're all aligned before activation and supporting through the early use of AID. So the closed loop insulin systems, we have structured onboarding and close follow-up to help optimize, usability, safety, and glycemic outcomes over this. This starts with, getting it approved, and then placement of that and instruction or education, and then follow up after that and improving management remotely, which is possible. So for our 62-year-old here with total daily dose of 68, we started the initial settings, basal rate of 2.8 units per hour, max basal of about 6 units per hour. And then, you can put in an insulin to carb ratio of 1 to 10 to 1 to 15, or even easier. What we really did was small, medium, and large meal, and we had it just set easy based on what they ate. They can just choose a set amount, and then also kind of correct for some increased blood sugar if that were present around the meal, and then have a target glucose of 110. And so these aren't really arbitrary. They were calculated from body weight and current insulin requirements, and then that's giving the algorithm a starting point. So the critical thing here really is that that this is initial settings only. And so over the next 1 to 2 weeks, the AEID algorithm is going to learn and from its total daily dose and amount and the glucose patterns that we see, adjust that basal parameters, in real time. And so, AID success in type 2 diabetes, requires really us having and using our team, our interprofessional team that we have. CDCES really provides education, behavioral support, critical for really addressing the patient psychology barriers we discussed. RNs and diabetes care specialists can help handle device troubleshooting and issues. And then we can leverage the manufacturer's virtual training and education and 24/7 support to really extend our team's capacity. So, the AID landscape, it's evolving rapidly. Hybrid closed loop systems really have transformed type 1 diabetes management. Now, new indications really expanding into type 2, exactly what we have been discussing today. The data confirms that the clinical trial results translate to actual practice, and these innovative algorithms are really targeting specific challenges that mealtime glucose spikes and exercise-induced potential lows do not. And, the remaining barriers really aren't technological. It's just implementation and access. So, Medicare and private insurance, really strong access. As we mentioned, DME-based pumps, we need to verify C-peptide status early for coverage. But for something not required for devices that are pharmacy-based insurance, that C-peptide does not come into play here. And then Medicaid coverage may vary and kind of remains state dependent. So primary care physicians, optimal, best place to manage type 2 diabetes. We don't require to have endocrinology, which may have limited access to initiating AID for our patients. And thus, the key is really having a structured team approach, using our team, our champions, to kind of ensure access, leveraging the manufacturer's support and training of the patient to use, and then just ensuring, compatibility with technology and using that to maintain, close follow-up to help manage. So really, in summary, AID, standard of care, this is something that we see for type 1. Well, it's expanded to type 2, and it really can make a difference. The evidence supports its use in type 2 diabetes. It is preferred now. It's preferred mode of insulin delivery in adults with type 2, and it can be safe to use. So when we're thinking about using this, become familiar with 1 to 2 systems, integrate that in, get to know your teams and the support teams for them, and then consider not really as a last option. These can be done with those that are on long-acting insulin alone or basal insulin, and really improve patient outcomes.
Thank you so much for your
Thank you.
attention.
Yeah, thank you so much.